Therefore, let's discuss the sedative hypnotic actions of these agents. Sedation can be both good and bad. It is a desired therapeutic effect, especially early in the treatment, during hospitalization, when the patients are aggressive, agitated, and need sleep induction. But in the long term, sedation is generally a side effect to be avoided because diminished arousal and somnolence can lead to cognitive impairment. Three particular receptors are responsible for causing sedation, and these are M1 muscarinic receptors, H1 histaminic, and alpha-1 adrenergic receptors. Interestingly, blocking central alpha-1 receptors is associated with sedation, while blocking the peripheral ones is associated with orthostatic hypotension. Central dopamine, acetylcholine, histamine, and norepinephrine are all involved in arousal pathways. Blocking one or more of these can lead to sedation as well as cognitive problems. Atypical antipsychotics, clozapine, quetiapine, olanzapine, and iloperidone are all more potent H1 antagonists than D2 antagonists. All other antipsychotics have moderate potency only, except lurasidone, which has essentially no binding to H1 receptors. And as for the anticholinergic actions, only the pines, clozapine, quetiapine, and olanzapine have high potency for muscarinic receptors. And there is essentially no muscarinic receptor binding for the other atypical antipsychotics. Coming on to the alpha-1 adrenergic antagonism, all atypical antipsychotics have at least a moderate binding potency to these receptors. But the most potent related to the D2 binding are clozapine, quetiapine, risperidone, and iloperidone. In conclusion, the pines are more sedating than the dones, and the presence of antihistaminic and antimuscarinic binding has implications for how fast one can taper or switch these agents.